we're recording, right?
I think so.
I hope so. Okay. This is my friend Jessie Dunn. I used to work with her at Ogden Regional. She used to be a hospitalist there. She is a family nurse practitioner, and she's been one for 8 years, since 2011. She works for AMG Senior Living. It's a smaller company, but it's growing. And she works with a team of 6 other NPs and 1 attending physician. Let's see. So tell me what your typical day is. Like, what is your work environment? What do you do at AMG Senior Living?
So AMG Senior Living has a couple different branches. We have a couple NPs that do family practice in the assisted livings. And then what I currently do, the program they're growing, is called At Home, and it's primary care in patient's home. I also do a supportive care program, which is post-hospitalization follow-up, trying to keep them out of the hospital. So it's very mobile. We all work very individually. We only meet once a month for our staff meeting, but we have our attending there if needed. So it's really, you set your own schedule, and I see typically, I would say now my census is lower. I only see about 4 or 5, but they're hour, sometimes a little bit longer. So we just have certain areas, I cover a certain radius and have my census of patients, and kind of the program I'm doing mostly right now is the At Home. So it's just like primary care. I follow up as needed based upon what I saw them for.
Okay.
So.
And do you like it?
I do. It's different. It's a challenge. You don't have all the tools accessible like you do in a clinic.
Right.
So a lot of it you have to rely on your assessment skills and stuff like that. And so it's a challenge that way. But patients are very grateful for it. You get to spend really good one-on-one time with them. But we do have mobile like labs, x-ray,
Oh, okay.
EKG. I did an echo the other day. So you can get some pretty good information, but so it's challenging in a different way of trying to, it's different in the home, but sometimes it's a little bit more relaxing.
Right.
So,
right. If you can think back to when you first started practicing as an NP, what was one or two of the biggest struggles you faced as you transitioned from RN to an NP or NP to DNP? So from RN to NP, what was your biggest struggle in that transition period?
I would say my biggest struggle was, at least my first job, I was working in the same hospital where I'd been a nurse. So having people recognize that job role change, right, in the new title. So kind of ran into some obstacles of, what am I trying to say? Kind of like the chain of command now, and just that whole thing. Another thing I think just in general, which I think it's common, is self-confidence. And it's kind of like with nursing school, like you know what you know, but then you realize how much you just, like you don't know until you get out there. And so just having that self-confidence and I think just feeling like, wow, instead of someone coming to me, or me going to like the attending or going to the nurse practitioner, and now people are coming to me. So taking on that, like, oh wow, like they're really looking at me for answers.
Right. So
I would say those two things were my biggest struggle.
Yeah, you are literally the one now.
Yes, and it's good, but it's scary.
Consider your scope of practice and regulatory bodies within your state. Do you agree with the regulations of your licensure designed by the state? Are there any changes you would make to the credentialing and clinical privileges in your place of practice?
I haven't ran into any obstacles so far at the jobs I've had. I've been pretty autonomous. I've got to do different procedures that were within my scope, you know what I mean? Like joint injections, minor procedures. I worked pediatrics, even learned how to do circumcisions, things like that. So honestly, with that one, I have yet to run into anything I'd say I would change. And it's almost it was very adaptive to what job I went to. If I didn't have a certain skill and they required, like I worked for electrophysiology and they wanted a cardioversion and they taught us how to do it. And we had to do so many with, a physician.
Right.
So a lot of it was on the job training and it was still within our scope. So I haven't ran into anything that I've seen or any changes I would recommend yet, but.
Okay. Do you consider yourself working in a collaborative practice? How often do you collaborate with other professionals? And can you provide a clinical scenario where you sought clinical consult with other professionals and how it helped with the patient's outcome?
Yes.
Because it sounds like you do that all the time.
Yeah. So we meet once a month, but we also have a secure text thread. That's the provider thread, and people throw out things all the time.
Mm-hmm.
I tried this medication for the patient's, itching. Didn't work. What else would you recommend? Or dosage on medications or recalls that we see out there, like recently, like the Zantac recall.
Oh.
They just recalled it because of carcinogens in it. So, people are saying, well, hey guys, are you guys starting to take your patients off of it yet? What are the recommendations? So we kind of bounce things off each other.
Mm-hmm.
I would say, as far as outcomes, I had a patient recently, she's homebound, she's a CHF patient.
Mm-hmm.
Literally, I can't do my basic assessment skills on weight and JVD and edema because she's just very large. She's non-mobile. She gets up out of a recliner 3 times a week, literally. So I kind of assessed what I thought, developed a plan, and then I just contacted my attending and was like, this is what I would do, what else would you do?
Mm-hmm.
And this is what I see. Probably because I was lacking confidence because I didn't have concrete things that I could see on assessment because of her size.
Right.
I'm not in a clinic. I can't get testing that, right then. I can't, she can't go out. Nobody could get labs on her. She was a hard stick. So I would say that, in regards to him, I called him, this is what she's on, this is what I want to do, but I'm worried, right? I don't want to increase her diuretics because I can't get lab work. What is her baseline labs? What's her potassium? So that's where it's hard in coming from hospital to then clinic, is that instant gratification of knowledge and making clinical decisions, but having him kind of guide me through, well, I would maybe try, torsemide instead of Lasix because of this. And we helped her overall respiratory status was the issue. And so I'd say recently that was one of the cases that he helped me with and gave me some good insight into, yes, I would do this, but maybe I would do this differently because of, this, and seemed to help her outcome so far.
That's awesome.
Yeah.
She's doing better.
Yeah.
So that's a perfect segue into one of my questions is, it sounds like you do work in a really awesome collaborative setting. Have you ever felt like you've been not acknowledged or disrespected as an NP because you weren't an MD?
I would say for the most part, no. When I was a hospitalist, I would think that was my biggest challenging job for multiple reasons, but primary care always been, even my patients, and the only time you run into it from a patient standpoint is the older population. They just don't understand what an NP is, right? But as far as other physicians in the hospital, I would say just kind of some of the specialized teams. And it wasn't so much they didn't respect you, but I think it was more of a doubt and kind of you had to earn their trust. And I would say that, but that's the one situation. But overall, I've never really felt minimized by other physicians. It's funny because if I've ran into that, it's been by other nurse practitioners.
Really?
That have kind of had I work with one that kind of has an inferiority complex. And so that's been challenging, but I have luckily never ran into any physicians that, in fact, I've had physicians that have come to me and say, I want you to come look at this. I want your opinion. I value your opinion, which makes me feel good, But I haven't ran into, I've had good experiences overall.
That's wonderful.
It's encouraging. And I think I'd say it's the biggest roadblock has been more so patients. I want to see a doctor. I thought I was seeing a doctor. right? Or like, I want to talk to my doctor, and that would be where I feel like not really lack of respect, but just the trust. I have met some very disrespectful patients, but the lack of trust in this, they're a little bit skeptical. So I feel like that's been more of a roadblock than with other clinicians, has been the patients.
Okay.
You know, they're very, I found it in the pediatric population because overprotective parents, right? And then elderly, they just come from a different generation. And then there's just some that are just very, I want a doctor.
I want a doctor. I don't know. Yeah.
When I worked as a hospitalist, well, when am I seeing a doctor? I haven't seen a doctor. I keep seeing you every day, but I don't see a doctor. And I explained from the beginning my role, how it works. Finally, there's some that just said, fine, you'll have to wait. And I let the doctor come in, and they said the same thing I said.
Right.
Then it seemed to not be a problem after that. But that's the biggest roadblock.
Okay.
For me, was been patience.
I wasn't expecting that. I would have thought that would have been like other clinicians. I'd be like, oh, you know, you don't have as much schooling as I do.
Yeah, no, I haven't really ran into any that. It's been more so I feel like I've had to fight for my title with patients. Okay.
And then my last question is, in general, like, how long did it take you to feel comfortable in your role as a nurse practitioner? Like having that confidence?
That's a good question. I would say it took me a good solid 2 years.
2 years.
But it was hard because I almost feel like there's a rule of thumb almost with if you go into like a specialty. Like, so I worked cardiology, the EP, and it took me, felt solid after a year. And then I had switched, and when I was in primary care practice, it took me a good year, almost 2 years to feel pretty solid in primary care because it's everything, right? And then I went to more of a geriatric population. Right. So then it's like, so it's almost like with me, at least each different specialty, it's taken me a good, they say like a good year to really get like a foundation. But in general, I would say like general competence coming out of school. Mine took me probably about a good 2 years to where I felt, okay, I know what I don't know, but I know enough. And I felt confident walking into even a new specialty and being like, I'm new to this specialty, but I have a pretty good foundation now in general. Right. If that makes sense. So I'd say about 2 years.
About 2 years is the adjustment period. Okay. Well, awesome.
At least for me it was. I don't know, maybe less or more for some people. And there's still some days like the geriatric population is like a whole new ball game. Like I'm learning, you know, and I do hospice as well. And so it's like, it's just, I feel like it's ever changing, learning, but once you get a solid foundation of even just primary care, then you can build on that. And it's interesting because my friend did acute care, so she always comes to me and says, okay, primary care stuff she is not confident in. Oh wow. So she comes to me, and having that primary care like foundation has helped me in every job I've gone to.
So would you say like when I graduate, like primary care, do you think that's where I should start out at to get that foundation and then kind of go from there?
I think so. Like, had I done it, like, if I were to do it over again, that's where I would have started. Okay. Because it was just primary care, although we think, okay, well, I work in cardiology or I'm going to work over here, but you have to have, okay, yeah, they're coming in for cardiology, but let's look at their thyroid. Let's look at this. Let's look at all these other general issues that play a role into what you're seeing them for, and medications, and the effects of what you do to them, or the medications you change or add on, how it could affect them. So having a general, I feel like, basis of foundation of just general primary care was instrumental to help in all areas. Okay. If I would have done it over again, I probably would have gone straight to primary care. Okay, that's awesome. Because then I feel like I was so specialized in cardiology. Then when I went to primary care, I felt like I had lost some time because I was like, well, I know a lot about the heart in this area. Right. But I got out of school and like all these things that were new and fresh, they like went away because I didn't use them. Right. And so it was almost like I was like restarting. So.
That's a good thing to
Yeah.
keep in mind.
Yeah.
All right. Well,
So,
thank you.
Yeah, thank you.
Thank you, Jessie.
You bet.